Hello everyone, welcome to my YouTube channel. Today I'm going to talk about compartment syndrome part 1. Before we start, there is a disclaimer. This video is for informative purposes only. I am advising you to refer to the main textbook or sources that is used in each teaching center respectively. Thank you. Now let's begin. What is compartment? It is a closed area of muscle groups, nerve and blood vessels surrounded by fascia. What is fascia? It is a thin, inelastic sheet of connective tissue that surrounds the muscle compartment and limits capacity of rapid expansion. What is a normal compartment pressure? The normal pressure is around 5 to 15 mm mercury. An acute compartment syndrome is a condition which there is an increase in pressure within the osseofacial compartment, resulting in impaired local circulation. An acute compartment syndrome is basically a clinical diagnosis and serial examination of affected limb. An intracompartmental pressure more than 30 mm mercury help in aiding the diagnosis of compartment syndrome. Pathophysiology of compartment syndrome. It occurs due to reduce in intracompartmental space or an increase in the intracompartmental fluid volume because the surrounding fascia is non-compliant. Normally, there would be an equilibrium between the venous outflow and arterial inflow. In acute compartment syndrome, there will be an increase in intracompartmental pressure that will lead to reduced venous outflow. There will be an increase in venous capillary pressure. If intracompartmental pressure become higher than the arterial pressure, there will be a reduce in arterial inflow. The reduce in the venous outflow and arterial inflow results in reduced oxygen causing ischemia that will lead to edema, and this will lead to an increase in the intracompartmental pressure. When this vicious cycle occurs, if the cycle is not intervened timely, irreversible necrosis may occur. What are the causes of compartment syndrome? It is caused by acute injury to the tissue within a compartment or an introduction of extra fluid, example blood, that will lead to further tissue destruction. The causes can be divided into intracompartmental cause, extracompartmental cause. For intracompartmental etiology, it can be due to 1. Fracture, example proximal tibial fracture, comminuted femur fracture, pediatric supracondylar fracture, that will cause bleeding in the compartment due to hemorrhage, vascular injury or coagulopathy. 2. Crush injury, that will lead to edema within the compartment. 3. Repercussion injury, post-revascularization procedure. For extracompartmental causes, example, 1 is constrictive dressing, 2. Constrictive circumferential cast that cause an external pressure, 3. Circumferential burns that cause an increase in capillary permeability, 4. Extravasation of fluid secondary to intravenous line leakage during fluid administration or chemotherapy drugs. Diagnosis of compartment syndrome is best determined by clinical examination and serial examination. The 5 P's is being used. The main is pain out of proportion despite adequate anesthesia and during passive stress test, paresthesia, pallor, pulselessness, and paralysis. The other 4 P's are lead in the evolution of compartment syndrome and represent irreversible muscle and nerve ischemia. Earliest objective physical finding is tense or wood-like feeling of involved compartment. Although clinical features are helpful in identifying the compartment syndrome, They have limited sensitivity and specificity. Other factors such as compartment pressure can help in making the diagnosis. When pressure are measured, delta pressure is more useful. Delta pressure is defined as the difference between the diastolic blood pressure and an intracompartmental pressure. Delta pressure is delta pressure minus the measured intercompartmental pressure. If less or same as 30 mm mercury, there is an indication for fasciotomy. Measuring the delta pressure is indicated in high-risk patient who has polytrauma, patient has a lot of distracting injury, patient who is not alert or unreliable, example, under alcohol influence or in a mentally challenged patient, and patient who is intubated. Pressure of each compartment is measured close to the fracture site as possible because that is the highest pressure or at the maximum swelling area. Methods for performing pressure measurement include Whiteside technique, wick catheter, slit catheter, striker stick system. I am going to explain regarding the Whiteside technique. Whiteside technique employs the following material: need 1 mercury manometer, 2 plastic intravenous extension tube, 2 18 gauge needles, 120 cc syringe, 1 3-way stopper, 1 3-way, 1 bottle of bacteriostatic normal saline. The extremity to be measured is clean and draped. Sterile saline is drawn into the 20 cc syringe, which is attached to the 3-way. A single intravenous extension tube is attached to the 3-way, and a second 18-gauge needle is attached to the other end. The third unused portion of the 3-way is closed off temporarily. The 18-gauge needle at the end of the extension tube attached to the 3-way is then inserted into the bottle of saline. Saline is then aspirated around half the length of extension tube. The 3-way is turned to close off this tube so that the saline is not lost during transfer of the needle. The second extension tube is then connected to the 3-way at its remaining open part, and its other end is connected to the mercury manometer. The saline containing needle is then inserted into the muscle of the affected compartment region. The 3-way is then turned so that the syringe is open to both extension tube, forming a T connection with a free column of air extending from behind the column of saline into the syringe as well as into the manometer. Pressure is increased in the system gradually by slowly depressing the plunger of the syringe while watching the column of the saline. As the plunger is pushed down, the saline meniscus will be altered from a convex configuration to a flat configuration when the air pressure in the system equals the interstitial pressure in the patient examined tissue. The manometer reading at this time is the tissue pressure in millimeter mercury. So how do you manage a compartment syndrome? For early management, immediately remove any constricting cast or bandage. Position the limb at heart level. Do not elevate the affected limb. This will reduce the arterial pressure. Adequate hydration via intravenous infusion and adequate oxygen supplement is helpful. For non-operative management, I will observe by serial examination when the delta pressure is more than 30 mm mercury with no clinical presentation of compartment syndrome. For operative management, I would do an emergency fasciotomy if there is a positive clinical presentation and the delta pressure is less than 30 mm mercury. I will cover regarding the incision for fasciotomy in part 2 of the compartment syndrome video. What is the differential diagnosis for compartment syndrome? 1 is DVT, deep vein thrombosis. 2 is cellulitis. 3 is gas gangrene. 4 is peripheral vascular disease. In part 2 of compartment syndrome, I will cover regarding surgical viva, how to do fasciotomy in the lower limb and upper limb region, complication that is associated with compartment syndrome, chronic compartment syndrome, and other additional question that is being asked during my exam in the master program. Hope the video is beneficial. See you in the next video. Take care. Bye.